Hello everyone. Today my topic of discussion is TE for structural intervention. So structural intervention is a part where the role of your cardiac anesthesiologist is not only for giving anesthesia but also acts as a imager or echocardiographer. So I'll be discussing few of the topics today. Now, what is so special for being an echocardiographer in this case of structural intervention? There should be one dedicated person only for the echocardiography, because otherwise it would be very much difficult for one person to manage both the anesthesia and hemodynamics and also for doing the echocardiography. Cardiac anesthesiologists are usually preferred because they are more eloquent with the TE and its nomology, and they can also manage the patient's hemodynamics much better because they can corroborate the patient's structural pathologies in concern, and they are more exposed to that person's hemodynamics and structural pathology. And another important aspect of uh, being an echocardiographer in the cath lab scenario, because there are unusual and changing location of echocardiographer in relation to the head end of the patient, because your position is not exactly as it likes to be in your regular operation theater. It's not at the dead end of the your head end. It's maybe at the right side of the patient or left side of the patient and very near to the your cath lab C-arm. So that is how you are also more exposed to the radiation, and your T probe movement also changes and varies with the patient's position. So what are the structural intervention where TE is actually mandatory? First and foremost is your mitral and tricuspid TER, that is transcatheter edge to edge repair, and transcatheter mitral valve replacement, transcatheter tricuspid valve replacement, left atrial appendage occlusion, and other procedures where TE can be useful. That is in case of your ASD, PFO or VSD closure, and in case of TAVR as well. But for the scope of this class, I'll be discussing only your mitral and tricuspid tear and left atrial appendage occlusion. Our first topic of discussion is transcatheter edge-to-edge repair of mitral valve. So in MTR, it is based on surgical alveolar stitch technique. It creates double orifice valve. Two devices are approved. One is MitaClip. Currently, fifth generation is running. There is G5, that is from Abbott, and Pascal from the Edwards system. So it opposes the AML and PML at regurgitant jet. While selecting the patients for the mitral valve TR, it is important to know what are the contraindications, because these are the points that you have to keep in mind while selecting the patient for MTR. First, the patient should not have any rheumatic mitral valve disease or any perforation in the leaflet body, vegetations or calcification in the leaflet tip. There should not be any thrombus in LA appendage, IVC or in femoral vein. Mitral valve area should be more than equal to 3 centimeters square. Mitral valve pressure gradient should be more than 5, less than 5 centimeter of mercury. Grasping length should be at least 7 millimeter or more than that. There should not be any hypersensitivity to the device component, or patient should tolerate the procedural anticoagulation or post-procedural antiplatelet regimen. These are the four cutoffs of for the successful mitral valve TEER therapy. That coaptation length should be more than equal to 2 millimeter. Coaptation length depth should be less than 11 millimeter. The flail gap should be less than 10 millimeter, or flail width should be less than 15 millimeter. Any center with lesser experience should start with a anatomically suitable non-complex uh, pathology for your MTR therapy. That should have a central pathology. There should not be any no calcification, and mitral valve area should be more than 4, posterior leaflet more than 10, denting height less than 10, flail gap less than 10, and flail width less than 15. And slowly, when the center's experience gradually increases, they can opt for your complex or very complex or challenging cases for EMTR therapy. But these are the criteria where replacement offers a better option for the patient, where concentric mitral annular calcification with stenosis with mitral valve area is less than 3 centimeters square. There is relevant mitral valve stenosis with mean gradient more than 5. Posterior mitral leaflet is less than 5 centimeter. There is a calcification in the grasping zone. There is a deep regurgitant cleft, leaflet perforation, multiple wide indentation, and rheumatic heart disease. These are the salient points for the anesthetic management. The patient is it is done with a GA with the endotracheal intubation with invasive hemodynamic monitoring with the target of avoiding myocardial depression and avoiding rise in the pulmonary vascular resistance. The tidal volume should be lesser with more rate because you don't want your heart to move a lot during your the clipping for the particular scallops of the mitral valve. And IV diuretic actually it helps in grasping because just before grasping if you give IV diuretic that actually decreases your left ventricular end diastolic volume, and that brings your scallops much more closer to each other. So that is how your these diuretics can help you to grasp much better way. And what are the concern for the anesthetic management? You have to keep in mind that you are dealing with a poor LV patient with NYHA more than equal to 3. Patient is usually more frail and it is already high risk for surgery. That is why you are doing MTR therapy. And there is a episode of acute increase in LV afterload just after clip placement. So prepare for potential acute complications like perforation, arrhythmia, air embolism, or device can embolize also. So this is a short video that actually gives you the idea of how this procedure has been done. This is the entire machinery that actually helps you to guide the clip into the mitral valve. So through the femoral vein, the axis has been made. Through femoral vein, you go into the right atrium, and then in an ideal location by the transesophageal guidance, you actually do a transeptal puncture. Through the transeptal puncture, you actually deliver your clip delivery system through the steerable guide catheter. This is a clip delivery system. Through that clip delivery system, the steerable guide catheter is inside your left atrium. Through left atrium, you have to manipulate and place it just above the regurgitant orifice. You check your devices, then you close it again, go in the LV, then open it again, make sure it does not entangle with your subvalvular apparatus, and then you clip your both the leaflets into the device and you close it. That is how you actually makes a two orifice and decrease the total regurgitant orifice. Now this is the removal of your steerable guide catheter and your clip delivery system. So this is your pre-operative and this is a post-operative situation. So what are the procedural steps? First is the transeptal access to the left atrium. Second is the insertion of the steerable guide catheter and clip delivery system into the LA. Then positioning of the clip in the left atrium. Number 4 is the clip advancement into the left ventricle and leaflet grasping. Number 5 is clip deployment and assessment of residual MR. And number 6 is withdrawal of clip delivery system and steerable guide catheter. Now first critical step is your transeptal access to the left atrium. Your aim is to puncture at the superior posterior part of the interatrial septum, and puncture point should be 4 to 4.5 centimeter above the mitral annulus at systole. So two orthogonal views are used: mid-esophageal bicable view that will give you a superior inferior orientation, and mid-esophageal aortic valve short axis view anterior posterior orientation. So this is your mid-esophageal bicable view that will give you a superior inferior, and if you put an X plane through that tenting, that will give you a reverse mid-esophageal aortic valve short axis view. So you can see over here, this is just an opposite image of your mid-esophageal aortic valve short axis view, where aortic valve is in the left side of the image. So that means more towards aortic valve is the more is the anterior position, and more away from the aortic valve is the posterior orientation. So at the puncture point, height should be measured at the mid-esophageal fourth chamber view, just like this. So as soon as your LA is punctured, interarterial septum is punctured, sorry, you should heparinize the patient with the SCD target of more than 250 seconds. Now the same steps are being explained in a more with more images. It is a mid-esophageal bicaval view. You can see this is your SVC, this is your IVC, this is your right atrium, this is your interarterial septum, and this is your left atrium. So this is your fossa, and this is your uh, thinner part of your fossa. So our idea is to puncture at the superior most area of your thinner part of your fossa, and this is your mid-esophageal aortic valve short axis view. Or you can, what you can do, you can just put an X-plane through your mid-esophageal bicaval view, that will give you a mid-esophageal aortic valve short axis view, and this is your mid-esophageal fourth chamber view, that will give you the height of the tenting. And this is a corresponding image of the fluoro image that you can see over here, as you can understand that you cannot actually see the interarterial septum or exact puncture point by fluoroscopy only. That is why your transesophageal echocardiography is very much crucial for this successful MTR. So you can see over here your guide wire is in the SVC, and it's slowly, and also the broken boro needle that is used to puncture the interarterial septum. So it is slowly coming down from your SVC, and you make a tent at your fossa, and that tent you can put an X-plane, and you can see it in the mid-esophageal aortic valve short axis view, where you can see how distant it is from the aortic valve. And after that, the same tent can be seen in the mid-esophageal fourth chamber view, where you can see the height of the image, height of the tent, sorry. Now you can see over here, while you making the tent, you can put an X plane and see if that plane is actually uh, touching anywhere in the LA wall. And in the 3D also, you can see over here, this is your LA side of your this is the interarterial septum, and you can see over here this indentation is your proposed site of puncture. And as you can see, as soon as the puncture is there, there is a immediate formation of bubble, and this is a clip delivery system, or sorry, this is a clip delivery sorry this is a clip delivery system is placed in the LA. And this is an image of your fusion imaging. That is it is a current modality where you can actually superimpose your 3D echocardiographical image over your fluoroscopy, where the performer can easily identify where exactly it is puncturing by seeing this superimposed image. Here you can see this is your tent formation, and this is your after puncturing. This is your needle. This is a similar fusion imaging. Now, as soon as the clip delivery system and steerable guide catheter are inside the LA, it is very important to continuously visualize the tip of the steerable guide catheter and clip delivery system, because either these tips are extremely sharp, and that can injure your LA wall. So you have to be very much sure that it is not touching anywhere in the wall. So you can put an X plane right through the exactly to the tip of your steerable guide catheter and your clip delivery system. So that is how you can know that it is not touching anywhere in the wall. Now next step is your positioning of the clip in the left atrium, where the principle is your guiding the clip to be above the grasping plane in the left atrium, and also the orienting clip arms perpendicular to the line of coaptation. The two views are used in this is your mid-esophageal bicommissural view and mid-esophageal long axis view. This long axis view is your grasping view, and 3D NFAS view of the mitral valve is also extremely essential for this step. So if you put an X-plane or biplane mode in your mid-esophageal bicommissural view, that will give you the mid-esophageal long axis view. So while positioning the clip in the left atrium, you'll have to understand that your mitral valve orifice is actually a smiley shape. So if you are actually want to clip A2 and P2, that means the orientation of a clip arm should be at your 12 o'clock 6 o'clock position. Whereas if you want to clip suppose A1 and P1, that means you'll have to orient the clip arm just like your 1 o'clock or 7 o'clock or 2 o'clock to 8 o'clock position. Whereas if you want to clip the A3 P3, your clip arm should be around 11 o'clock 5 o'clock or 10 o'clock 4 o'clock position. So depending on where you want to clip it, your uh, clock position also changes. So this is very important. And the second image you can see over here, this is your midesophageal commissural view, where you are putting the X plane through that clip, and while putting that X plane through the clip, you can see the grasping plane also in the long axis view, and you can also see that the arms will be visible only in your long axis. Now you have to advance the clip into the left ventricle through the mitral valve orifice. So we have to make sure that clip is in the closed position, that you can see over here the clips are in the closed position. Otherwise the clip arms can actually injure your mitral valve leaflets. In the LV, again the clip arm should be opened, and you make sure there is no subvalvular apparatus getting entangled, and you can see in the upper image and what is the closed position and what is the grasper. So these are the actually grasper that actually grasp the leaflet in two. So this is the clip arm and this is the grasper. Next step is your dropping of your grasper onto the leaflets, so that you have to identify if both the leaflets are equally and adequately grasped. You can see in the right sided clip the both the leaflets are into the grasped condition and they are not moving too much. That means they are well inside the grasping zone of the clip. After that, the leaflet is it is closed, and then you can put the colored Doppler again to see if there is a what is the residual MR, and if there is a residual MR, and also you have to check for what is the gradient of your mitral valve right now. If the gradient is too much, that means you have created the mitral stenosis, and also you have to ensure the mitral valve orifice area is also adequate, so that there is no iatrogenic mitral stenosis is there. And also if there is a still the gradient is not too much and the gradient is acceptable, but still there is a adequate MR jet that you can see over here, by putting an X plane through the particular jet, you can actually put another or more than one clip for a successful TEER management. So what are the complications of TR? It's the iatrogenic injuries, device embolization, atrial septal defect, mitral stenosis, worsening of mitral regurgitation. It is very important because if you actually injure mitral valve leaflet even more, that can actually worsen your mitral regurgitation. Worsening of LV failure because there is an acute increase in your LV afterload. Air embolism and arrhythmias. You can see over here This is a after removal of your clip delivery system and your steerable guide catheter, there is a residual opening of your interarterial septum that is giving you a left to right shunt. So usually it is not treated, but if it is a larger one and if it is also causing a right to left shunt, if there is a increased pressure in the right side, that in those scenarios these orifices are also device closed. Next, our topic of discussion is the transcatheter left atrial appendage occlusion. So what are the indications? The patient with non-valvular AF, there is a very important non-valvular AF with at increased risk of thromboembolic stroke, that is Chadwick score is more than equal to 2 in case of male or more than equal to 3 in case of female, and it's suitable for at least short-term antithrombotic therapy and no other indications of oral anticoagulant or than non-valvular AF, and there is an appropriate anatomy of the left atrial appendage occluder. So this is a small video how the procedure has been taken place. It is done under general anesthesia in a catheterization lab under fluoroscopy and transesophageal echocardiographical guidance. Similarly, your femoral vein is access has been done. Similarly, your transeptal puncture, but the site is different than your TEER therapy. Then pictal and guide into the left atrial appendage and your device placement. And this is further endothelialized. So what are the transeptal puncture based on the procedure location? So in case of your left atrial appendage occlusion, it is infero-posterior. It is the ideal location for your uh, puncture for your left atrial appendage occlusion. Whereas in case of a TEER or TMVR, it is mid to superior in case of a superior inferior axis and mid to posterior in case of a anterior posterior axis. There is four variations of Lele appendage. There is number one is a cauliflower. This is a cauliflower shape. Number two is a windstock shape. Number three is your cactus shape. Number four is your chicken wing shape. These are the devices currently being approved from the FDA for the left atrial appendage occlusion. Number one is a Watchman device. Number two is Watchman Flex. Number C is the Amulet device. So these are the measurements that you'll have to take. There is a ostium, that is from the left circumflex up to the superior border of your coumarin ridge, and just 1 centimeter inside the left atrial appendage, that will give you the narrowest portion of that is the neck, and also it is the landing zone for the device. And also you have to measure the length. I'm coming into that. So peri-procedural management, it is mostly done under general anesthesia. It is either TE or intracardiac echocardiography guided with fluoroscopy. Systemic heparination immediately after transeptal puncture as usual. Target ACT is around 250 to 300, and careful dearing of the delivery sheath and occluder device. It is very important and critical step. So procedural echocardiography, at first and foremost you have to rule out if there is any intracardiac thrombus and also if there is any thrombus in the left atrial appendage. So that is a relative contraindication for immediate placement of the device. Number two is the transeptal puncture at the inferior posterior of the IS. Left atrial appendage measurement should be done, especially when left atrial pressure is more than equal to 12 millimeter of mercury. So whenever the left atrial you are entering into the left atrial cavity, any catheter placed in the left atrium will give you the pressure of the left atrium, and if it is less than 12, then you'll have to infuse the patient with the IV fluid you have to load the patient so that your LA pressure will increase, and that will give you the adequate size of your left atrial appendage. Otherwise, your size may be under appreciated. And real-time guidance of the wire and catheter into the LA appendage, that is also very important, and biplane imaging of the angle and the depth of the device deployment, and finally the torque test to check the stability. So these are the measurements that you'll have to measure in your four angles that you have to measure. Number one is your at a 0 degree, then 45 degree, then 90 degree, and your 135 degree. So whenever you are actually imaging for your left atrial appendage, you have to make sure that you have to keep the left atrial appendage just at the middle of your screen, so that whenever you are changing the angle, there is a your left atrial appendage is not actually moving away from your screen. So when try to make the left atrial appendage be imaged at the center of the screen, and then you change the angle. And also you just decrease the depth of the image so that you can see the left atrial appendage as your maximum possible resolution and your maximum possible size. So these are the measurements that you'll have to take for the amulet, that is for the neck, and also for the ostium. And also for the watchman measurements, you have to take the neck and also the height of the or depth of the left atrial appendage. So that is how your 3D MPR of your left atrial appendage will give you the exact orifice size of your uh, left atrial appendage. And this is a 3D, and this is your 3D MPR that will give you the two diameters of your left atrial appendage ostium. Now this is the 3D MPR through the uh, device placed in the left atrial appendage, and you can see over here this is the 3D NFAS image of your device being placed. And also you have to see whether the device is being tilted or it is well oriented and well seated inside the LA appendage, otherwise it may gets dislodged. So it's very important to understand whether it's being compressed or whether it's being loose or tight in the particularly LA appendage. So after post procedure, you have to check for your device compression, that is maximal width at the center, so that you can deduce from your 3D MPR, and it reflects how well the device is anchored and expanded. And device diameter at the center in the multiple TE views is taken, that is 0 degree, 45 degree, 90 degree, and 135 degree, and it is compared with the original size. So compression percentage is being calculated by normal size minus measured width uh, divided by normal size into 100. And for the watchman device, the normal compression is 8% to 20%. So if it is less than 8%, that means the device may get dislodged, or if it is more compressed, that is more than 20%, that means it may actually causing compression your adjacent structure, for example your LCX, causing your lateral wall ischemia. For post-procedural evaluation, you have to check for your peri-device leaks. So up to 5 millimeter of leak is acceptable, and you have to decrease your color flow Doppler at Nyquist limit of 25 to 35 to see for any peri-device leak. So you can see over here, these are the various example of peri-device leak, and you are putting an X-plane through that, and you can measure the width of the device leak. Now post procedure evaluation, you have to see for deployment depth, whether it's positioned too far outward towards the LA cavity or oversizing. It actually may compress LCX causing ischemia. And if the device is capturing the warfarin ridge, that means your LA disc resting on the ridge as opposed to inside the LA appendage, that means it has a more risk of embolism. So warfarin rich capture is also very important to identify in your TE examination. Now I will give you a brief scenario of your transcatheter edge to edge repair tricuspid, and it seems to be more complex than your mitral counterpart. Now, a brief recap of the views where the tricuspid valve are seen and the leaflets that we can identify. So, in mid-esophageal four-chamber view, uh, the leaflet attached with the septum is your septal leaflet, and another is your either anterior or posterior, depending on where it is cutting. In deep esophageal four-chamber view, at 0 degree, usually it is a posterior leaflet and your anterior leaflet. Whereas in your mid-esophageal reverse four-chamber view, it is just the opposite of your mid-esophageal four-chamber view. Deep esophageal reverse four-chamber view, it is just the opposite of your deep esophageal four-chamber view. Then mid-esophageal RV inflow-outflow view. In the RV inflow-outflow view, it is a very important yeah, view. So that is you the leaflet nearer to your aortic valve is your usually anterior leaflet, and another one is your posterior leaflet. And by putting an X plane, you can actually go to the mid-esophageal four-chamber reverse view, where uh, if you are cutting through the anterior, then you will see the coaptation between your septal and anterior, and if you're cutting through your posterior, you will see the your coaptation between your septal and posterior. This is a transgastric short axis view or en-face view. You can see over here, this is your anterior, this is a posterior, this is your septal, and this is your septum. And further, in a 3D TE view, it is just similar to your 3G SAX view. So here is your anterior, this is your septum, this is your posterior, and this is the septum of your interventricular septum. And deep transgastric RV inflow view, where you can see over here, this is your uh, anterior and your posterior leaflet. It is just an uh, enlarged image, where from the RA view, from your 3D, you can see over here, this is your septum, this is your posterior, this is your anterior, and if from the RV, septum is downward in your 6 o'clock position, this is your anterior and this is your posterior. So the anterior and posterior are getting changed if you just rotate it through your trackball. Now this is one of the most important view that is most important for this procedure. That is mid-esophageal RV inflow outflow view at about 50 to 70 degree, where your tricuspid valve remains mostly at the center of the screen, where you can see your anterior leaflet and your posterior leaflet. Anterior leaflet is close to your aortic valve and posterior leaflet opposed to that. And this, if you put an X plane through the posterior leaflet, that will give you a reverse four chamber, giving a coaptation between your septal and the posterior leaflet. And if you put an X plane through your anterior leaflet, that will give you a reverse four chamber with the coaptation of your septal and anterior leaflet. So by this, you can see over here, this is the triclip, and you are putting an X plane, and that will give you the uh, clip orientation in your reverse four chamber view. So this is a 3D MPR through the clip that you can see over here, and you can see the 3D of your clip arm, and this is your corresponding fluoroscopy image. So this is your closed position of your clip, and this is your open position of your clip. So and this is also your open position of the clip, as you can see in the 3D MPR. So this is where you can put another clip. It is an image of putting another clip. You can see over here, this is a clip over here, and you are putting another clip, and you're putting an 3D MPR through the new clip, and you can see only one clip it in your red plane, because your red plane is cutting through the newer clip, so that you can see only one clip in this image. You can see over here, after putting both the clips, these are two clips, and you can see there are almost nil or no residual MR, or sorry, TR, or and there is no tricuspid stenosis as well. And this concludes today's session. Thank you so much.